session. Um, a very big, warm welcome to all of you who have joined today to our monthly clinical meeting, teaching, and respiratory update organized by the respiratory chapter of West Bengal Academy of Pediatrics. We choose this time intentionally because we hope that, we have put our professional work to rest, and we kind of look forward to this little bit where we enlighten ourselves, revise what we know, and share our dilemmas. So talking of dilemmas, the topic for today is, we are snowed down under. By we, I mean the pediatric fraternity, with the fever, the cough, the cold, the fever that doesn't seem to subside, the cough that doesn't seem to go, and the numerous viruses that are responsible. The parents' anxiety and the pediatrician's dilemma. So coming to the topic for today is too many viruses, too little answers, dilemmas in office practice, a very apt topic to the problems for this season. We have wonderful speakers today, but before I go on to that, I must take this opportunity to thank our host, Dr. Reddy's, for sponsoring this academic meet tonight, the meet that starts at 8:30. Thank you very much for being a part of this academic meet by sponsoring it. We have with us today Dr. Shubhashish Rai, who really needs no introduction. He's the secretary of the respiratory chapter of West Bengal Academy of Pediatrics and the moderator for this session. The experts who have joined us today, both from Kolkata and from the rest of the country, we have with us Dr. Indu Khosla, well known to many of us, but I will just take 2 seconds to reintroduce her. She is a consultant pediatrician and pulmonologist at Lilavati Hospital and Research Center and NHSRCC Hospital for Children, as well as being a director at Dr. Indu's Newborn Childcare Center. She has a special interest in bronchoscopy, sleep medicine, and mucociliary disorders. All those of us who have been a part of the various ATM and the RTI modules, we do know that she is a co-faculty for the ATM module, the RTI, and the under 5Bs module for IAP. As having multiple publications, she has also been a national convener at the NAPS module on sleep. So a very warm welcome to you, Dr. Indu, and thank you for joining us.
Thank you so much.
We have a very senior pediatrician with special interest in pediatric pulmonology, who has been the past president of IAP Thane branch. We have with us Dr. Prakash Vaidya. He has been the joint national convener for the asthma training module, the co-convener and the writing committee member of the under 5Bs module, as well as the national trainer for the IAP NTP TB module and the NRC cough module. Needless to say, with various publications in indexed journals. Dr. Shomik Ghosh really needs no introduction. I was just wondering, what would I say was his USP? His calm and gentle demeanor and his ever-ready smile with a hand to help for all occasions? Or was it the debonair Dr. Shomik Ghosh with his beautifully colored Punjabis that he wears? Well, I should say he is the founder secretary of NKP, as well as being its current president. He is the EB member of West Bengal Academy of Pediatrics. Most important, and he will really be disappointed if I did not say so, he's the organizing secretary of the National Conference on Adolescent Medicine. So with this, with all these experts on board, I would now welcome Dr. Subhashish Rai to start the session. And once again, a big thank you to Dr. Reddy's. Over to you, Dr. Subhashish.
Thanks, Debjani, for kind introduction. Now, initially, the keynote talk will be given by Dr. Prakash Vaidya, and the topic is when the infection goes viral. Dr. Vaidya, the stage is yours.
Thank you very much. I'll just share the screen. Is this visible? Hello, is my screen?
It is visible. It is visible.
Yeah. So a very good evening to all of you, and thank you very much, Pulmonology chapter of West Bengal, and specifically Dr. Subhashish, Dr. Debjani, and all the office bearers for this kind invitation. I'm really privileged to share this platform with all of you. And the topic is, when Subhashish talked, I said the first thing that struck me was that what is happening today is that infections are going viral. Now we know as pediatricians that kids often have recurrent infections. I mean, that forms the basis of our practice. And we all know that most average kids have 4 to 8 respiratory infections in a year. And there are so many of them. But what is so specific this year is that infections have truly become viral. And I don't need to explain to all of you what viral means. It means really that it's a self-replicating thing. It travels from child to child through across all channels. And we are all inundated with cases of viral infections. So what I'm going to do on this short talk is that a look at the prevailing scenario. Let's try to make sense of why this all is happening in the post-COVID times. I'll share some case stories with you. And then we'll talk about, can we come to a more precise diagnosis of these viral infections? What are the tests available? How to use and interpret them? And finally, does such a diagnosis make any difference to the treatment at all? We'll try and touch some of these issues. So we know that there are an overwhelming number of infections today. I'm really surprised that so many of us could finish by this time because we are all overwhelmed. So we have widespread, virally spreading frequent infections, and we all know that they are the usual ones. Some of them are unusual. We have the hand, foot, mouth disease type of viruses, which are enteroviruses. Then we have respiratory, influenza, para-influenza, RSV, rhino, metapneumo. The list is endless. We have dengue, which has always been in the background. In Mumbai, it is probably less than what is there in Kolkata. We have rotavirus, and we have COVID that has never actually receded. It's always been there. Plus, we have some new diseases, or maybe these are new media nomenclatures, like say tomato flu. There is an outbreak in India, which was published. There was a article in the Lancet recently, and we don't know whether it's an enterovirus or some new virus. But whatever is the truth, this is a recurrent scene in our clinics, and this is the new normal. That every mother is tearing out her hair and saying, give me something to increase my child's immunity. So this presupposes that children have poor immunity. But we all know that as pediatricians, that is not true. Is it truly a SPUR? And SPUR is the well-known acronym for immunodeficiency. And that is infections which are serious, persistent, unusual, and recurrent. So none of today's infections mostly fit into this SPUR story. Of course, as pediatricians today, we are more savvy, and we know that antibiotics are not needed for many of the infections, but parents think otherwise. And many of them still think that antibiotic deficiency is the cause of fever. So they tend to demand antibiotics, some of them. But the new concept that has come today is the immunity debt. What is immunity debt? So quite obviously in COVID times, we were all protected. The kids were in a bubble. There was lockdowns, there was hand washing, social distancing and masks, and the spread of the virus of COVID was therefore suppressed. As a byproduct, most other viruses also got suppressed. So the interaction that we had with all these viruses truly reduced, and therefore our immunity took a backseat. So today, there is an absolute resurge of infections, and all of them are back with a bang, and the immune system is not that prepared to confront them. As an epidemiologist, Dr. Michael Baker explains, it is like a bushfire. If you have some years without bushfires, the time when the bushfire occurs, it's very severe because there's a lot of fuel lying on the ground. So something similar to that. So there is definitely this concept of immunity debt. But one of the other reasons that we see so many infections today is that we are doing increased testing. And this we learned from COVID period when every single thing was tested. And today CDC advises a lot of RSV tests there. We all do, some of us do a lot of flu tests. So immunity debt and increased testing means more infections. Let me quickly share with you a few cases of flu. These are not strictly office cases, but they all began as office cases. So I'm just going to rush through these cases since I don't want to spend a lot of time on those. This was a child, an 11-year-old boy, who came with fever, vomiting, cough, altered sensorium for 1 day. His nasopharyngeal multiplex PCR detected influenza AH3. So this was the X-ray, and this child also developed acute renal injury, which is well reported in children with influenza virus A today. So this child finally, did well. Then I had another child, 3-year-old girl, previously presented again with fever, altered sensorium. The important part was that her influenza was A, positive, non-H1N1. And there were hemorrhages in the brain, but I'm not going to spend time explaining this case. The third case was a very interesting case. This child came with acute wheezing, very severe wheezing for the first time in her life and required PICU admission. So we thought it would be the usual virus like a RSV or a rhinovirus or something. But what we found there was a flu virus, H1N1, causing. So we are getting a lot of serious flu. And when we go back in time, what is alarming is that all three were previously healthy children. All three progressed over 3 days. So we know that today influenza is a serious problem. And many of us are giving oseltamivir on suspicion. The question is that we are testing and we are doing only H1N1 swab in many of the hospitals. Is that enough? And I will discuss that in a little while. A word of caution, which I don't need to give to people in Kolkata, is that swine flu and dengue can be absolutely overlapping in terms of symptoms, and let's not miss any dengue. I'm sure none of you need this thing, this suggestion. So now the wheel has gone full circle. At a time when we tested COVID every single day for every single patient, COVID testing has become debatable now, but we are more focusing on H1N1 and the cost of the test is very, very high. So my question to the house is, are viral RTIs only a diagnosis of exclusion or can we test for them upfront? So today we have tests available for them upfront. It is not a diagnosis of exclusion. So the other possibility is doing these tests an idea whose time has come? Which viruses can we detect? Well, we can detect all the respiratory viruses, influenza, para-influenza, HS, respiratory syncytial virus, rhinovirus, metapneumovirus, adenovirus, corona, SARS-CoV-2. And we can also detect things like enterovirus or herpes. Now, most of us are dealing with bronchiolitis patients. So let's see, is it really worth even picking up that this is RSV? So one thing, let's realize that in this period of immunity debt, when infections are more severe, we have been getting studies across the world where RSV, which was just causing a seasonal epidemic in winter and not causing too many admissions, many of them were outdoor, now has become in a more severe form. And there are 2 studies from New Zealand as well as from the US, where intense spike in RSV, para-influenza and human metapneumovirus activity, and the cases became more frequent and more severe. But my question again goes, is it really worth proving that this is RSV? So many viruses cause a bronchiolitis-like syndrome. It is RSV, metapneumo, rhino, so many viruses. So if I know the virus, does it alter the management? Does it change the prognosis in any way? Let me take a case. This was a child of 8 months with fever, cold and cough, typical bronchiolitis-like story. The clinical diagnosis was bronchiolitis, the standard line of treatment, which probably meant giving oxygen, giving hydration, possibly giving hypertonic saline or a trial of bronchodilator, but the child was not improving. This was the X-ray. So now sometimes we have to do tests because the parents drive you. They're affording parents. I happen to be attached to a corporate hospital, so a lot of my patients demand the test. So they demanded the test, and this test showed human rhinovirus, enterovirus detected, and then RSV also detected. What do I make of this report? So let's look at the available data on the subject. That can you detect a virus in an asymptomatic child versus a symptomatic child? And yes, it is found that a lot of asymptomatic patients do carry viruses. They may carry 1 or they may carry 2. But it is also known that children who are with disease, they carry a higher burden of these viruses. But today, PCRs are only qualitative. We are not having quantitative PCR. And that means we don't have any cutoff level. So this we learned in COVID. COVID, we had those cycles. I don't know, but even the ICMR said that do not go by the cycles because a lot depends on the method of collection and the timing. So there is a lot of here, which is a gray area. But it is possible that if you can have a cutoff level, you will be able to tell with more certainty whether this is a nasopharyngeal carriage versus a true pathogen. So then coming back to this, how do I interpret this report? So when this same study told us that 47% of healthy controls carried rhinovirus. So, however, when you look at RSV, it was rarely detected. So that there is a high probability that if you detect an RSV or a HPMV or adeno, there is a high probability that it is a true pathogen. But if you detect the rhinovirus, it is quite possible that is a 50% chance that it is a carrier. So when I come back to this report, I would probably ignore this completely and say that, yes, RSV detected. So this was RSV bronchiolitis. So RSV could always be pathological. Rhinovirus is a bystander. But why was this test needed apart from the parental, parental insistence? So really, there is no recommendation for viral testing in an otherwise healthy child with bronchiolitis. Now, somebody might ask you, okay, let me know if there is RSV. Is there a simpler test? Is there a less expensive test than a PCR? And yes, that test is available. That is a point of care test, which is a rapid antigen-based testing. And it is available for a cost of maybe less than 1,000 rupees. So we can do this test and we get an answer within 30 minutes. But what is the outcome? Is it going to change if I just do this test, and does it really matter? So when there was a study of a large cohort of bronchiolitis, and the children who had repeated symptoms, recurrent wheezing, problematic bronchiolitis were the ones who were in the ICU, intensive care. So maybe children who are genetically predisposed may also be predisposed to severe wheezing in the first instance. And secondly, a history of eczema was found to be an independent risk factor correlating with severe bronchiolitis and post-bronchiolitis recurrent wheezing. But there is one study which says that RSV versus non-RSV, RSV episodes are more severe compared to non-RSV, and you can cohort these patients and determine the prognosis. So there is at least one study which says, okay, there is some point in doing an RSV testing. In my practice, if I find a child as in having an RSV positive, if I happen to do the test, I know mentally that this is a child who's going to have repeated wheezing in all likelihood, and his present cough and wheezing may not settle immediately. So I think one takeaway which I have learned, which may or may not be, it's not really a guideline, but I do in my practice is that I put these patients on early MDI with spacer, because these are the children who will benefit if they are wheezing with inhaled medicines more than a child where you might think it's a first episode and get away with oral. But I know in this child, it's going to be long, it's going to be repeated, and I would introduce him to inhaled medicine much earlier. Also, as a corollary, I might do an early ICS trial in such a child if he gets recurrent episodes. But in this particular child, if I happen to do a routine blood test and do a CRP and CBC, and I find the CBC is high, does it mean, the CRP is high, does it mean I should be giving antibiotics? So in a large study of 565 children, only 1.2% had subsequent infection. So even if you do a CRP, take home messages, RSV does not need antibiotics, even if the CRP is high. So now let's look at the respiratory panels that are available. We have so many respiratory panels, which are multiplex PCRs, which are one of the known ones is BioFire. So do we use it, and does it change our practice? And are there any pitfalls? So the first question is, should I do a test or not? How will the results affect my clinical management? So I would do a test if the patient has got severity of illness, or I'm really wanting to rule out something else, or there is a severe comorbidity, like say a congenital cardiac disease. He's in a state of immunosuppression. And most importantly, the turnaround time is low. What's the point of doing a test where the lab will give you the report after 5 days? So the turnaround should be within a day or so. In addition, it helps me to interpret the test better if I know the pre-test probability of a given pathogen. If I know the clinical context in which I'm doing, then the pre-test probability, if it is high, then only the value of that assay is high. If I randomly pick up something from a child who is otherwise not showing the same symptoms, the pretest probability is low, and I am not looking at, I will not take a positive result very seriously. So this is one disclaimer about the test. The second is, which test is best? Should I do a point of care test? Well, for influenza, it is 100% sure that we are interested in a PCR, not an antigen test. But now many hospitals are doing only H1N1 because that is cheaper. Maybe it costs only a couple of thousands. But as I showed you in my 3 cases, only 2 were H1N1 and 1 was A. And I'm sure if we do only H1N1, you might end up missing influenza A, and you'll certainly miss out influenza B. So we talked to our hospital and we got a package, which is an influenza virus package, A and B both. And that came at a fraction of the cost of the of the multiplex PCR. So I am not really interested in the multiplex PCR when I suspect flu, but I do want to cover A and B both. But then let's understand that with influenza, too many conditions apply. If I get a negative antigen test, does not mean influenza is not there. A positive test does not mean that other respiratory pathogens are not there. A positive test for another pathogen does not exclude influenza. So there are too many conditions apply. And one of the most important things that I need to share with you is I had 2 patients who had encephalitis with influenza. But when we asked for the tests for influenza virus in CSF, we could not get it. Why? Because the tests are not validated according to our lab. And not only our lab, even Hinduja doesn't do. So most of the labs in Mumbai are not doing CSF flu. It's only a matter of contextual diagnosis that the nasopharyngeal shows influenza and the child has got has a encephalitis. So probable cause of the encephalitis is influenza. But unless you really get a validated test from the CSF, you can't swear and say that. So what is the impact of respiratory tests on clinical outcomes? Possibly they reduce the antibiotic use, they improve antiviral prescribing, and they shorten the hospital stay in some cases. So I had a very interesting child who was in the US and now they have come back here. And since post-COVID times, this child had 4 infections almost on a monthly basis, all RTIs. So interestingly, now there it seems to be the standard of care that they would do a nasopharyngeal PCR every single time. So each time this child tested for a different virus. Once it was RSV, once it was metapneumo, once it was something else. Well, I really got confidence from this child to tell my patients that, look, your child is getting repeated infections, but it could mostly be a different virus each time, though we are not testing, because there are so many viruses and immunity to one virus does not transfer to another. But before you get an idea that these tests are absolutely useless, I'll quickly share a couple of cases with you that the tests can be really useful in some situations. And this was a child who had fever, cough since 4 days. The long and short of it, he was in a private nursing home, admitted for pneumonia. And on day 9, he was transferred to us because they thought he needed tertiary care. And this child had a bad pneumonia. We did not know the etiology. His reports were quite inconclusive. So we did all the tests for mycoplasma we tried to do, and we did a nasopharyngeal swab. And this child's swab grew, of course, the usual rhino intro, but also came positive for adenovirus. Now, just this one test is not enough for me to conclude that this was an adenovirus etiology. This child also was on antibiotics, but subsequently he failed to improve, and we also did a BAL. And in the BAL, we actually got adenovirus and we did not get any bacteria in that. So this gave us confidence to withdraw the antibiotics, continue supportive treatment, and this child did well. So this was a case where we really found the viral test very useful. There was another child who came with croup, whose multiplex PCR showed para-influenza, because again, it was done because the parents wanted an answer. It showed para-influenza. So how did it help me in any way? It helped me because I knew that here there was no role of oseltamivir and I didn't need to give the antiviral drug unnecessarily. So if I have some time, I'll quickly take an overview of the enterovirus situation. Otherwise, what I will do is we will leave it for the panel. But we are seeing this all the time, hand, foot, mouth disease. Luckily, the complications are less. But let's understand one thing, that if it is Coxsackie A16 and enterovirus A17, These are the most common serotypes of enterovirus which we see, but serious complications are there usually with enterovirus 71. Can we identify this from the specimens? Very difficult in the Indian scenario. And again, this is what they do in Korea. They found it in the CSF, but here I don't think that the test is available for that. The other thing is that so many people feel that because the blisters are like chickenpox, they would give acyclovir. So the genome of the enterovirus does not encode for thymidine kinase. So here acyclovir is not required and does not help. So there are a couple of studies which we will discuss as the panel comes. So I think I'm running out of time. So what I'll do is I'll just sum up what I have to say, that there are multiplex PCR platforms which show multiple respiratory pathogens. The differentiation of carriage from true infection may always be a challenge unless you get a quantitative test, but we are still very far away from a quantitative test. Co-infection also poses a challenge when there is more than one virus, which is the virus responsible. So ultimately, a clinical correlation is a must when a delayed clearance of a virus like adeno. And I'll tell you that if you in a multiplex PCR, so many times, the pathologist will tell you off the record that, yes, doctor, I've picked up flu, I've picked up adeno, I've picked up RSV, but I've also picked up COVID-19. Now, COVID-19, as per government regulations, cannot be permitted to be released on a multiplex PCR. They have some rules for that. But I do not know if this COVID-19 was a carriage or the child is actually having a infection with both the organisms. So that's really a challenge to diagnose, especially when you pick up two viruses. And when you know from the data that some of them are carriageable and some of them are viruses which are actually causing an infection. But one thing that I think, let us get a take-home understanding that in a flu season, excessive antibiotics are prescribed all across the world. So probably by doing at least the flu test, we will reduce the misuse of antibiotics. So to conclude, what are my take-home messages? That tests for diagnosis of viral infection are available, but we need to interpret them very carefully. We need to counsel the parents regarding immunity debt, the importance of isolation. Today, how many children go to school within 3 to 4 days of the illness? Majority do. So isolation is done only in isolated cases, really not done commonly. Tests can be of practical value in terms of reassurance, avoiding antibiotic abuse and targeted antiviral therapy. Certainly useful in immunocompromised patients, diagnosis in very sick patients. It may help in infection control, and it helps epidemiologically, it helps the community to take a rational decision, possibly on the vaccines and possibly on the type of therapy. So there are some tests there are some good points of the test, but they are not a common thing to be done by you and me in every patient. They have to be done in selected patients and they have to be interpreted with care. But the most important thing today we tell today's parents is realize immunity debt, isolate your child for at least a week and take vaccines, especially for flu, and take all the precautions. So with that, I thank you for your patient hearing and I will stop sharing the screen.
So thank you, Dr. Prakash, for a brilliant talk and left very little room for my panel discussion. I do not know how much interest I can generate in the audience after this talk, but let me share my screen. Just 1 second. And what you have covered, basically, I will go for the more office-oriented talk than the intensive care or what to be done after the hospital admission. So my discussion will be more towards the office practice. And we have 3 stalwarts with me, Dr. Prakash Vaidya, Dr. Indu Khosla, and Dr. Shamik Ghosh. Basically, Prakash Vaidya is the Lal Bahadur Shastri of India. He is so knowledgeable, but so down to earth. Indu is basically Indira Gandhi. And she is like beautiful and she is flamboyant. She has a very good international communication with all the faculties in different parts of the world. And she knows her business. And Shamik Ghosh is Narendra Modi. He is phenomenally good organizer, has taken New Kolkata Academy of Pediatrics to a greater height, very eloquent and very good organizer. And so when these stalwarts are there, so my job is very easy to take a cup of coffee and share with you. So my first, now the viruses are spreading slightly at a lesser pace than the CBI. Now CBI is spreading much more faster throughout the country than the viruses, but still viruses are a menace in our office practice, and let us see how we can discuss some easy cases which will be coming to your clinic very frequently. Sanaya, 4-year-old female, was fine in the morning, went to school. At 4 p.m., there is an abrupt rise of fever up to 104 degree Fahrenheit. Grandmother noted the SpO2 is 89%, but the child is alert and conscious, and the child is talking very normally. Now, rush to the hospital. In fact, this is a case which I have seen in the hospital emergency. I was there in the hospital, and the grandmother was extremely anxious. The SpO2 is 89. Now all the parents, and in fact, all the human being in the globe knows what is the cutoff value for SpO2. So what to do? Will you admit, Dr. Shomik Ghosh?
Thank you, Shubhashish sir. Okay, so here we have a 4-year-old, and as Dr. Roy has just mentioned, that there's been an abrupt rise of temperature, probably a legacy of the COVID times, that almost every house has a pulse oximeter. And most of the pulse oximeters, which are conditioned better to be reading oximetry readings in adults, has been used over here for the child. So one of the first things that I will make sure once I see this child in the ER, of course, after having gone through the A, B, and C and made sure that the child is well, I would recheck the SpO2 as one of my first steps before I press any panic buttons in the family or around me.
So whenever a child is coming with fever, do you advise to the parents to check the SpO2?
Generally not, because at home, very, very few of them would have the appropriate probes. And for a child who is alert, conscious, feeding well, and is otherwise playful, there would really be no need for checking for any hypoxemia.
Exactly.
Because
so the take-home message from the case is that in a normal viral fever, until and unless you have diagnosed COVID, it is unnecessary to test and check and recheck the SpO2, because most of the children at the height of the fever, they have peripheral vasoconstriction.
Absolutely.
And as a result, most of the children will land up with a lower SpO2, and the parents will be extremely worried and shaky. So it is not necessary to ask them to check the SpO2, rather to discourage checking the SpO2 until and unless you are having COVID. Because very few viruses on this earth are there which can produce lower SpO2 just because of the infection per se. 4-year PJ not eating and drinking well since last night. Mild fever since morning. Parents notice rash on the body parts. Next day, the rash look like this and ask, is this a monkeypox? Dr. Indu.
So I think all of us know, right now I feel at my clinic, we should have a hand, foot, mouth counter, because the staff nurse who they come in saying that this child has got the staff nurse who brings the child in says this child has got hand, foot, mouth. So we are all seeing a lot of cases of these kind of lesions. And I think Dr. Prakash Vaidya has covered that it is caused by enteroviruses or the Coxsackie virus. And typically these are lesions in the knees, the foot, the ankle, and in the oral cavity and the buttocks. Now, this is not monkeypox, because if you were to think about monkeypox, the rash is definitely different. First of all, we're not seeing it. I mean, there are a few case reports in the world and even from some from India, but we are not seeing monkeypox so rampantly as we are seeing the hand, foot, mouth disease. The incubation, the type of distribution of rash for monkeypox is definitely different from what it is in the hand, foot, mouth category. And the type of rash, it belongs to the same family as the smallpox virus, the vaccinia and the variola virus. And therefore, the kind of eruptions are more like vesicular eruptions all over the body, including the hand and feet. And again, you need to have exposure to some kind of, so human beings and monkeys for monkeypox are accidental hosts. So basically it's seen in rodents where they are the carriers for the virus. And most of us adults who have taken the smallpox vaccine would have some cross protection against it, and we would probably not get it. It's a mild disease, though it takes a longer time to resolve. It's a mild disease. So definitely I would comfort the parent to say that this is not monkeypox.
And very few of the pediatricians have seen the monkeypox. In fact, I have not seen. I do not know whether you have seen.
No, we've not seen.
Can I add one couple of things?
Yeah, sure.
One is that, like it was in COVID times, we used to ask travel history. Today, monkeypox, we are probably justified in asking a travel history because there are mostly going to be cases from people from West Africa or somewhere in the parts of the world where it is prevalent. And it's a serious systemic infection. Probably a child with hand-foot mouth is not going to be so sick. So,
Yes.
Of course, I have not seen a single case which has been proved as yet, but parents all the time start wondering whether it's monkeypox
Yes.
for sure.
And it basically starts from the extremity. Then it is a centripetal distribution. Starts from the palm and sole, and then comes to the trunk. Whereas chickenpox starts from the trunk and distributes towards the periphery. Cervical lymphadenopathy is a very important distinguishing point between monkeypox, chickenpox, and this hand-foot-mouth disease. And normally, this is entirely a theoretical discussion. There are 6 stages of monkeypox. It is initially there is an early vesicle, then a small pustule, and then just one second. Then comes this umbilicated pustule. Then it gets crusted, and then the scab falls off and it gets sealed. So that is the basic stages, and monkeypox yet not very rampant in pediatric population. Dr. Vaidya, hand-foot-mouth disease, harpangina, herpes gingivus stomatitis, all starts with oral lesion. And many of the hand-foot-mouth disease, in fact, yesterday I have seen a hand-foot-mouth disease, no lesion on the body. And only the parents came with a sore on the tongue, and the rashes erupted today. So how to differentiate? This is one point. And the second point I would like to ask you, have you seen any complication, serious complication of hand-foot-mouth disease? I will ask to all the panelists whether you have seen any serious complication like encephalitis, pancreatitis. Theoretically, they may happen in hand-foot-mouth disease. And whether you will caution the parents that yes, some complications may happen, but it is rare. So first part of the question is, these 3 oral lesions, how to differentiate? Dr. Vaidya.
So HFMD and herpangina are essentially both enteroviral. So they are pretty similar. HFMD, of course, we know starts in the mouth, and then there are exanthem, which are distributed on the hand, feet, face, and buttocks. But as you rightly said, we are getting so many variants, some with only enanthem, some with only exanthem, some with enanthem followed by exanthem after a couple of days. And also, quite surprisingly, we are getting 3 episodes of hand-foot-mouth back to back in the same child. I don't know, that also is another thing. Now, herpes gingivus stomatitis is a different creature altogether. I don't think we can. It's a very painful thing. The whole gums are swollen. The lesions are there on the gum, on the cheeks, on the lips, as well as on the tongue. And there is usually fever with that. There is sometimes is bleeding from the lesions, which you will not see in hand-foot-mouth. So, and this is the person where you would be giving probably acyclovir. So herpes gingivitis stomatitis, there is going to be gum lesion, which are not going to get gum swollen and bleeding in a child with HFMD and herpangina.
So basically the differentiating point between HFMD, herpangina and herpes is that the herpangina will be restricted basically to the anterior pillars of tonsil. It does not cross the posterior third of the tongue. HFMD distributed all over the tongue, cheeks, etc., but you will not get an inflamed gums. And gingivus stomatitis, the child will be toxic, high temperature, gum involvement will be there. And one very important thing is that if the child is having a bad atopic dermatitis, then the rashes of HFMD may persist for a longer period of time with a bad secondary infection, and which can pose a serious problem to the children. Acyclovir already Dr. Vaidya has said. Indu, you want to add anything so far as the complications?
I would say that acyclovir, though recommended for herpetic gingivus stomatitis, it's recommended if it's recurrent. So first episode, maybe you will not give it, and if it's recurrent, then there is some place for using it.
There is.
And as you've already mentioned, the location of these lesions are very different. Herpangina and HFMD is basically the same virus. And I would say Herpangina is only the oral part of the HFMD. That is the only thing. And you asked for if you have seen any severe manifestations of this kind of disease. I had one child where I had extensive HFMD. I mean, that was a kid. There was not a space left. It started as a mild disease, but it spread so much, and it was an immunocompetent child. It spread so much that there was not an inch left on the child's body without the lesions. And also, the oral cavity was full. I had to admit this child, and then because the child's intake had become 0, and this child was in the hospital for a week. The scars took more than 8 months to go.
Yeah. This is a subset of population, though it is rare, but it can happen.
Yeah.
Shamik, a child with abrupt rise of...
I just had one point that you can get a cutaneous rash in herpes as well, but the rash is asymmetric as opposed to a symmetric rash of HFMD. So if at all you get a rash on the outside, it doesn't rule out herpes. The second thing is that while I completely agree with Indru about immunocompromised or recurrent one, there is definitely a case to give acyclovir in a child who is very sick with herpes, even though it may be the first episode.
But in cases of herpes zoster infection, Dr. Prakash, the rash will never cross the midline. It will be unilateral and distributed.
No, not herpes zoster. I'm saying that even in herpes,
okay.
Stomatitis, you can get a cutaneous rash.
Yes.
But it is asymmetric.
Yeah.
Right.
The other point that I would like to raise is though the books described that these are diseases of the younger kids up to age 7 or 10.
Yes.
I've seen a couple of adults also get it. So we are seeing it has kind of spilled over to adults also at this point of time.
I have not seen adults, but 18-year-old I have seen.
I've seen a parent of a child with HFMD get an HFMD, but it has been mild in the whatever adults that I've seen. I've seen about 4 to 5 adults, but it has been mild in all of them.
Okay. So
the complication I have seen is poor intake. So that's the only thing they require admission for is IV for a day or two. That's it.
Yes.
No CNS. Yeah. Sorry.
Thank you. So child with an abrupt rise of high temperature, not well responding to paracetamol. Is there any clustering of the viral, any specific virus you can think of, Shamik, in this situation? Because many of the parents are complaining, that's why I am giving paracetamol, the fever is not responding. It was 104, now it is 102, and the child is not comfortable. So any viral correlation with this type of symptom, Shamik?
Yeah. I mean, with such an abrupt high rise of temperature, we would definitely be thinking about the viruses which, are not usually nasopharyngeal carriage, and viruses which are more pathogenic. So I would, in these situations, think or rather keep my index of suspicion very high for the influenza viruses as well as for the adenoviruses. Because
and also dengue.
Also, of course, not to forget dengue.
Yeah. So why there is this question has been already answered by Dr. Prakash. I am not going into the details of that. During a febrile illness, Shamik, are you advising for PCR in those children who are coming with upper respiratory tract infection? And the parents are asking whether we should test for the COVID-19. What is your policy in the OPD?
Very debatable question, and I'm sure the House is going to have some opinions over here. We do recognize the fact that the mortality with COVID, as was seen initially, is certainly lower as of now. It is becoming more and more endemic as time will pass, and we will have to change our requirements for testing. But what is very important with children is that they are in very, very close contact with the elderly parents. So elderly grandparents or elderly caregivers. So we do have a case where I suspect that a child is very, very unwell. I will certainly go in for a COVID testing in the OPD where the risk of transmission is very high to an elderly person or somebody with a comorbidity.
Can I add a point here?
Yeah. What is your policy, Indu?
What I would do in such a situation here is if I have a child with comorbidities, then I would definitely, and if I suspect COVID, I would definitely test for COVID-19. Apart from that, we have educated parents today, and many of them would directly ask you whether it's COVID-19. Upfront, I would say that there is no way for me to know whether it's COVID-19 or not. I would give the pros and cons to say that Today it is a mild illness, and in pediatrics it hardly has any consequences. But many a times I leave the decision to the parents. If the parents insist that they want to test for it, I would say please go ahead and test. But upfront, I am not advising unless I find risk factors, or there are certain, say, as Dr. Shomik mentioned, there are senior citizens at home and the parents are concerned about it. Yes, then I would say go ahead and do it. Otherwise, I am not routinely doing a COVID-19
So
test.
basically, this strain of COVID is infecting the upper respiratory tract, and nasal symptoms are more common than the LRTI. So routine investigation is not so necessary as it was 1 to 1.5 years back. Dr. Vaidya, have you seen
children are coming with diarrhea also, which is also
Yes.
a manifestation of COVID, and there even if you test, the test would still come negative.
And this is a very interesting study where it has been found in the East India, the RSV is very predominant. Adenovirus is highest in eastern part of India. Para-influenza virus, East India outnumbers all other Indian zones, but rhino higher in West India. Influenza highest in the northern India, and metapneumovirus east and west divided. The honor is shared equally between east and west, and so please remember that this is the distribution. But again, that is nothing to decide your practice or your advice for the investigation. But this is a very interesting fact I am sharing with you. Now, 6-year-old SR sudden rise in temperature. She is having sore throat, mild conjunctivitis, disturbing cough. Grandma is suffering from the similar disease. It is a wealthy family. Second day, a pediatrician advised for CBC CRP. It is 3,200, CRP is 30. Third day, parents come to you and change the any change in treatment and asking for a NPA PCR, which they can afford. Dr. Vaidya, you have already answered. What will be your answer?
So if the parents demand, the tests are available, and we should definitely say go ahead, because I'm really more concerned here about swine flu. And while I will not, especially if the child has not received flu vaccine, in a child who is severely ill, I would definitely seriously get high-grade fever. I would start oseltamivir upfront, irrespective of the report. But to answer your question,
will you say yes for the testing, or you will counsel them?
I will counsel them that we may not always get an answer, but many times they hardly hear that part of your counseling. So if they are ready to spend, I am ready to tell them to go and do it. We have no need to stop them from doing it, but I would not upfront recommend for sure.
The other thing I would think is, if you have a conjunctivitis, a bad cough, a sore throat, adenovirus, pharyngoconjunctival fever is another differential that I would keep in mind. So if the child is very sick here, I would monitor this child. If the child is very sick and shows lower respiratory symptoms, then I think a nasopharyngeal PCR may be of some role.
Now, if I put the question in the other way, the parents are not asking for an NPA PCR. Will you advise it?
Yeah, with the conjunctival congestion and grandma also suffering from a similar disease, with the leukopenia, I will certainly keep adenovirus as one of my differentials. And because adenovirus can deteriorate, especially in children, and become a very protracted long course, this is something I would certainly do.
So on the third day, will you advise for PCR?
It depends on the clinical condition of the child.
This is a clinical condition. The child is otherwise hemodynamically stable.
No, if the child is hemodynamically stable, feeding well, and has no other issues.
Well, because the child is febrile and coughing, not feeding very well.
Right. So if the child on the third day, no, I will not advise a PCR, NPA PCR.
I might do an X-ray a little early on the child like this, who's coughing and showing me a lower respiratory. And if I see something going wrong there, then maybe I would be more.
Exactly. I completely agree with you. NPA is, in my opinion, NPA is reserved for those children who are very severely sick and admitted in the hospital, where you need a guidance, whether to start antibiotic, whether to start. Here, I can start oseltamivir. I will go for an X-ray, then advising for an PCR. Now, temperature touching 105 degrees Fahrenheit. Is it possible in viral fever, Indu?
Yes, 120%.
Okay. So this is a very common question. Temperature not responding to paracetamol, what to do? Shomik.
Well, I think so. Here, our patient counseling skills are going to be very, very important. And when we are doing our well baby checkups, and this is entirely from a general pediatrician's point of view, if we get any opportunities, we have to explain to parents why does fever occur as a natural phenomenon. We need to explain to them that this is a naturally occurring phenomenon wherein the heat of fever also kills a lot of germs. And we gradually need to counsel them away from using other antipyretics or get into some panic-filled measures like trying to bathe the child or do a cold sponging. At best, what they can do if they are not responding to a standard maximum dose of paracetamol of 15 milligram per kilo is advise tepid sponging. That's about it.
Okay, so I have two more questions with these questions. Are you prescribing mefenamic acid?
No.
No. Are you prescribing ibuprofen?
Never.
What is the meaning of non-responding? I give you two scenarios.
Exactly. That is exactly what I wanted to ask. When you say non-responding, do you want the temperature to crash to the baseline? I tell
Exactly.
the
I am just coming to that. The child is having 104-degree fever. You have given paracetamol. After 1 hour, the temperature is 101 degree Fahrenheit, but the child is comfortable. This is one situation. Second situation, after 1 hour, the child is having 103 degree Fahrenheit and the child is not comfortable. What you will do?
So basically, I always explain to every parent that we are not treating the fever, we are treating the discomfort. That is part of my counseling in every single, because fever is a defense mechanism. I don't want to reduce the fever. I'm only treating the discomfort. So if the child has become more comfortable after lowering the temperature by even a couple of degrees, then that is response to paracetamol, in my opinion. I would not like to go ahead. Now, if there is no response, as in that the fever continues to rise in spite of paracetamol, then I would probably give ibuprofen within an hour and a half or so.
Yeah,
Right.
I would agree with Prakash completely. I always try to counsel my parents even this way, that the first day of any infection, so especially a viral infection, the viral load is higher, the body is not prepared, the fever is not going to come to the baseline. It is only going to come down to a little bit and to rise again. It's as though the body is fighting an infection, but still the body is not prepared for the onslaught of a new virus. I definitely use ibuprofen. See, in real life and real life, things are sometimes very different. You may tell the parents, and the parents will come and tell you, my child does not respond to paracetamol. This is the very common statement, that paracetamol does not work on my child. So I feel sometimes we do have to use ibuprofen. And if the fever is going above, provided there are no other risk factors or contraindications to using ibuprofen, like a G6PD deficiency, etc. And in some kids, I've seen even fever going up to 106 and 107. There it becomes a definite necessity to bring the fever down. Yes, I agree with Prakash. It is to reduce the discomfort, but if it's hyperpyrexia, then we definitely need to work.
Then you put it in the AC room and do everything.
Put it in the AC room.
And whenever the temperature is crossing 105, it is hyperpyrexia, or 105 when it is touching. So cerebral malaria, encephalitis, all the Japanese encephalitis, all these things should be kept in the mind, especially
rapidly rising bacterial infection, urinary infection, malaria are your close differentials when you have such, along of course with viral fever like dengue.
And please do not use mefenamic acid. Ibuprofen is as safe as paracetamol for a short-term use. You can use, but mefenamic acid is not indicated in pediatric age group. In the temperature
reason, even in a regulated market like the US, ibuprofen is an OTC product.
Yes,
I wonder why.
Absolutely.
There are studies to show that it is as effective and it's safe to use it for a short duration.
Duration of time. Temperature subsided.
Can I just make one submission here? That whenever we are advising fever management, we have to touch upon hydration, because most of these patients will have higher rises of temperature if they are not adequately hydrated. So it is a difficult proposition, especially on day one. But whenever we are making out our prescriptions, especially for fever, we must make a prescription also for keeping these children well hydrated. That would help a lot of these children and reduce their discomfort.
Fine. So next question is temperature subsided, very common scenario. After 3 days and returned after 2 days, Indu, What's your answer?
Many
Or
of
how?
these viruses have a biphasic pattern of fever,
Yes,
especially dengue, and even the influenza virus has a biphasic
influenza
pattern.
can also happen.
Yeah.
Yes, yes.
So then, in fact, we should counsel our parents right in upfront in when we have these children with viral fevers.
I think the
This
majority
question,
of fevers today are biphasic.
yes,
Or
many of the
you don't know whether it is a biphasic fever or a second virus which has come in. Sometimes it is as confusing as that.
Yeah, that is also very important. This question has been answered. Acha, any one of you know any?
Can I just make a submission again, Subhashis
Yes,
sir?
yes, sure,
Yes,
sure.
temperature had subsided after 3 days, returned after 2 days. Much as we all are encountering what you say biphasic fevers, as my seniors have just now spoken, would we not keep a secondary bacterial infection as also a possibility? That is important for us.
So if there is a cough and which is a wet cough, or there is a tachypnea,
Yeah.
Child is getting toxic, then you should think of secondary bacterial infection and treat accordingly.
If you're thinking of like a protracted bacterial bronchitis as a secondary infection on a underlying virus, or probably a viral fever with a necrotizing pneumonia which comes secondary, the child will really be very sick. In
Very
most
sick,
of
yes.
these biphasic fevers, the child is not sick. In
Yeah,
fact, the intensity of fever is also lesser. So clinical will help us differentiate between a secondary bacterial infection. Yes, if the patient is admitted in a hospital, probability of a secondary bacterial infection is higher. Then your other parameters also, your blood work will definitely give you a pointer towards that.
Definitely. So the next case, 5-year male, 4 days of fever, bad cough, sore throat, came to you with an NPA-PCR report, and the NPA-PCR shows it is an influenza A positive. The child is not that bad. The child is not tachypnic, having fever. And the treating physician asked for an admission as it is influenza A positive, and repeat the PCR to identify H1N1. Dr. Vaidya, what you will say?
First of all, repeat PCR serves no purpose because you have already got influenza A positive. You're going to get it positive for a long time. I don't see how it serves. If the physician has not started oseltamivir, I would start, though it is rather late in the day, even 4 days later, for whatever the worthwhile. And the admission, I will decide on merit. If the child is sick, tachypnic, poor intake, I will admit. Otherwise, I would not really admit merely because it is influenza, just as I would not admit merely because it is dengue NS1 positive. That is not a modern sign.
So the take-home message is that it depends on the condition of the child, not whether it is influenza A and H1N1.
Yeah.
And the treatment for all subsets of influenza, A, H1N1, B, C, whatever you get, it is oseltamivir. So no point of asking for a repeat PCR to identify H1N1.
Yeah, I'd like to make a comment here that I have read some data which says that if you have a sick child and if the fever continues, you can use oseltamivir even on day 8 and day 9, and it does work. So
Yes,
there is data to suggest though what we have read earlier, that earlier you give the better, it works better in the first 48 hours. But yes, if you have a symptomatic child, you can use it at any stage of the fever.
And this year, from my experience, I can say some children who are having a fever and very bad cough coming to you on 4th or 5th day, giving oseltamivir, if the child is having, without doing PCR, I have seen many of the children improve dramatically on 5th or 6th day after giving oseltamivir. Though the recommendation is best if it is being given on the 2nd day, empiric antiviral therapy is often necessary. Do not wait if you think of. Do not do a repeat PCR if you get influenza A, and usual duration of therapy is 5 days, and longer duration of therapy if there are any risk factors.
Subhashis, before we proceed, can we have a little bit of clarification? Because when physicians go to prescribe oseltamivir, there is a prophylactic dose and there is also a curative dose. So in what situation, when we're using it within the first 2 days, I think we are using more of it as a prophylactic dose. So whenever, what you say, whenever we are getting it later, we are using more of the therapeutic dose, because in the first 2 days, there is very little indication either for testing or even getting a clinical picture, which will prompt me to give an oseltamivir on day 2.
I am not aware of the prophylactic dosage because I use only as per the treatment protocol depending on the weight band. I am not aware of the prophylactic. I think prophylactic is applicable only for the contacts.
Yeah, but even
That's only
chemoprophylaxis
immunocompromised
no
contact,
longer,
not for routine
yeah,
contact.
not for routine. Chemoprophylaxis
routine,
has now
yes.
been given up by WHO as per WHO
It's
recommendation.
given up now.
So I have only 8 minutes left. So let me rush to the cases. 4-year male, low-grade fever for 10 days, continuously coughing into 4 days. The treating physician said it is pneumonia and bronchiectasis, and to be admitted came to your opinion. This is the X-ray. The total count is 18,050. Neutrophil 65, lymphocyte 30, CRP is 43, and PCR is staph. Dr. Indu, what you will do?
So, however, we would have loved to have, our investigation as simple as a nasopharyngeal swab to tell me which bacteria caused my pneumonia or my lower respiratory infection. Unfortunately, today, as things stand, maybe these BioFire is actually a brand name. I would say respiratory PCRs.
Panel,
Panels are more predictive of only viral infections. Okay,
Yeah,
and there also.
With this blood count, CRP and X-ray, will you admit this child with
No.
with a thought of pneumonia
No,
or
no,
bronchiectasis?
not at all. Not at all.
Not at all. Okay,
Not
fine.
at all. Yeah. So bacterial infections on PCR are not reliable is the message that I want to give. The only where it is reliable is for to some extent for MRSA.
Yeah.
Not otherwise.
Probably there are peribronchial coughing, which is also a hallmark of the viral pneumonia
Absolutely.
and viral infection. So that's why the physician was misled and thought it is a bronchiectasis, but this child needs no admission.
I will add one thing, that mycoplasma from nasopharyngeal PCR has got a high amount of predictive value.
Yes.
What?
Yes.
Mycoplasma.
But mycoplasma still can be a commensal. Huh? So you
Can
have
be,
to,
but it is likely
you
to be a
have to-
pathogen in the right context.
yeah, you have to have it in the right clinical context.
And
So,
there is a paper from PGI Chandigarh by Joseph Mathew, where he has very clearly demonstrated that mycoplasma is not that common that we think in India. In Indian context, mycoplasma is not so common. A quick case, 5-year past history of severe allergic rhinitis, no asthma, fever, cough, runny nose for 3 days. High fever, continuously coughing, saturation is 86%, admitted, tachypneic, bilateral wheeze, started ceftriaxone and vancomycin. Given oxygen, salbutamol, ipratropium, back-to-back nebulization with little improvement, HFNO and steroid. Now, the PCR shows metapneumovirus and staph. My question to Dr. Vaidya, will you stop vancomycin and ceftriaxone?
Now, this is a little...
X-ray is not that bad. This
Yeah,
is the
I need an
X-ray.
X-ray.
This is the X-ray.
So X-ray is clearly showing a picture of bilateral hyperinflation. It's not showing a breakdown areas like Staphylococcus. So, and with a metapneumovirus, which is highly likely to be the pathogen, I don't think I would go overboard with vancomycin right now.
I would need to differ. In a sick child, the guidelines are very clear. In a sick child, when you're thinking of, even if it's a community-acquired pneumonia, staph comes high on the list. I would, if it's a community-acquired, I would not jump to MRSA, but I would definitely give staph coverage and watch this child. Because this is a window period. If you have staph,
It was vancomycin, not anti-staph.
so I would give anti-staph, not vanco. That's what I'm clearing. That if it's community acquired, I would cover MSSA.
But
I would cover
staph
Peptidemol.
in PCR has a very little value. It can be commensal.
In
With
PCR,
this X-ray.
so I'm not even looking at the PCR. I'm not even looking at the PCR for
Okay.
staph.
Okay.
I'm looking at a sick child who's desaturating. And then if I want to cover, I would cover staph pneumonia and staph till I have clarity on which way this child is going.
So for the benefit of doubt, for the sake of the improvement of the child, you want to continue anti-staph medication. May not be vanco, you may give co-amoxiclav.
Yes.
And so far as the PCRs are concerned, these 4 viruses have highest correlation with the disease occurrence, that is RSV, parainfluenza virus, human metapneumovirus, and influenza virus. Rhino has the lowest correlation with the occurrence of the findings. I am going to the last case.
And the metapneumovirus is known to be does not like other viruses to co-inhabit. So many a times you will get metapneumovirus single virus.
Yes. So multiple positivity in PCR, the detection of more than one virus in a single sample is common and usually does not reflect more severe disease. In one study of the otherwise healthy children in daycare, 46% has multiple viruses detected. Of those, 2 viruses were detected in 61%, 3 in 25%, and 4 viruses in 11%, and 5 viruses in 2%. Detection of multiple viruses does not warrant investigation for underlying immunodeficiency. This is the red alert or red flag signs for a child who is having fever, who needs admission, pale, mottled, and feel cold to touch, blue lips and tips of the fingers, severe breathing difficulty. Most of the scenarios are very well known to you: fits and seizures, extremely agitated, crying inconsolably, rash that does not disappear with pressure. This is known as a glass test. It differentiates from the petechiae. This is a glass test. If you press with the glass, it will not blanch if it is a petechiae, and that may differentiate.
Commonly we used to do for meningococcal infections.
Meningococcal. Basically, we do for a meningococcal. Yes, absolutely right. Is the last case. 12-year-old, 3 weeks fever, cough for 5 days, and there is a weight loss. This is an X-ray. Yes, Shomik, what you will do? What is your provisional diagnosis?
So going by the latest, NTP guidelines that we have all been exposed to, we have got a child with 3 weeks fever, with the fever and the cough in the last 5 days. The weight loss needs a little bit more of quantification. And if it is more than 20% of what it was prior to the illness, then I think here is a adequate case for us to be investigating for tuberculosis.
And there is a lung abscess also. It's showing a lung abscess here in the right upper lobe. Yes, Indu, you want to add anything?
So it's like a cavity, sorry.
Yeah, there's a lung abscess or cavitation, thick walled cavity.
Yeah.
And this is the CT. HSCT thorax reveals consolidation in the right upper lobe with air bronchograms within, multiple discrete and confluent nodular opacities, parenchyma apico-posterior segment of the upper lobe, findings likely to represent active infection or pyogenic. We did a RT-PCR and it showed, though it is low, the TB. My question is not going to details of the TB management. My first question to Dr. Khosla, Dr. Indu, whether you are getting more TB cases post-COVID era?
See, I don't have a double-blind study to tell you yes whether it is more or not, but definitely I've seen more TB in the last 1 year than I have seen earlier. The kind of different changes that I'm seeing in TB now is, first of all, I've seen a lot of children with TB with extensive lymphadenopathy, mediastinal lymphadenopathy, and making diagnosis even more difficult, because unless you do a lymph node biopsy or you do even if you do a bronchoscopy and BAL, you don't get sample. So you'll end up doing a lymph node biopsy on these kids to get a microbiological lead. The other different things that I've seen in children with TB, I've seen children with no fever. 2 weeks, or they have just come because the X-ray showed something abnormal, or they picked up a lymph node and they have all got TB. I have got 2-3 children as late as last month with big cervical lymph nodes, no fever whatsoever, and you do a biopsy and then it turned out to be tuberculosis. Also, I've seen 3 kids with immune reconstitution, again, which I have not seen so commonly in the past. And again, this was something which has come in post-COVID, where we have seen tuberculosis. I've seen children with tuberculous meningitis. I've had 3 kids with complete destruction of one lung, with complete collapse of the lung following tuberculosis. So I've seen extensive TB. I've seen disseminated TB. I've seen TB with different presentation in the last 1 year. Yes, I think we are seeing more TB, but I don't have statistics to prove it or disprove it, because unless I do a double-blind study, I may not be right in making a statement like this.
Great. Dr. Vaidya, you have you confirm that what Dr. Indu said, or you have a different opinion, or your observation in last 1 to 2 years, so far as the TB is concerned? Dr. Vaidya?
You're mute, Prakash.
In the post-COVID period, I've had 3 cases of MDR TB. So it clearly underscores the importance of doing CBNAT very, very vigorously in each and every case. Do 2 samples, do either a induced sputum or do a gastric lavage. Train your residents properly on how it is done, because today with a expert ultra, the yield is good. And I think we should not start AKT without making a great attempt to look for bacteriological evidence in the form of CBNAT. And of course, send the sample for sputum culture. So I have had a lot of scary MDR TBs in the last post-COVID phase.
Okay. Dr. Shamik, you agree or you have any other opinion?
Yeah, I mean, I would tend to agree with my seniors from whatever they have commented, because even for us who are doing general pediatrics in our clinics, we are having to refer more cases. I do not have any statistics to say that I'm getting more of a positive, what you say, output from these referrals. But certainly we seem to be seeing more and more of these cases wherein the fever is prolonged, the cough is prolonged, and there is also a definite weight loss.
Okay. So I will spend only 1 minute. This is a child who is 13-year-old child. After an influenza infection, the child is was having sore throat, cough. 2 other family members had similar problems, and the PCR was positive for influenza. Initially, there was an X-ray which was normal. After 7 days, there was a collection, and it looked like an empyema, and clearly there is a meniscus sign also here. So there is a fluid as well as consolidation. This is a CT, and the drain was given. Now, my question to Dr. Khosla, in this case, whether you will give drain only versus drain plus urokinase, your experience, and drain plus urokinase versus VATS.
So it depends on how quickly you pick up the empyema, whether it's in the first stage, whether it's in the serous stage, or in the purulent stage, or the fibrinopurulent stage. The key message here is that you need to drain it. That is for sure. Okay.
Yeah.
Whether you are going to add urokinase or you're going to only drain it, I think it varies from center to center and from case to case. There's nothing right or wrong about it. Okay, you can only drain it and leave it alone. You can do a primary VATS if a patient is affording and wanting to go ahead with it, or you can do a secondary VATS if it is a loculated. If it's a loculated fluid, then you would do a secondary VATS. So I know of centers where they would go ahead and do a primary VATS if resources are not a constraint. So there's no right or wrong answer. But here, what I would think is it depends on the clinical condition of the patient. Drainage is a must, either through an ICD or a primary or a secondary VATS if it's loculated. Urokinase can be tried before doing a VATS. So if you have a child, you have done a drain and the child is not settling in and the child has loculated fluid, you can try an attempt at urokinase before subjecting the child to surgery, is what I would do.
So all of you agree, Dr. Prakash? Do you have any other opinion?
I'm a
Dr.
little
Shamik?
biased for VATS because our pediatric surgeon prefer a VATS, and if the patient is affording VATS, is the best.
Absolutely.
Secondly, of course, it totally depends on the locules. If it is loculated, then there is no other option. If it is non-loculated, you have option only of drain.
But they are globally, there are a number of studies where they have found the drain plus urokinase is as good as VATS if it is done in a proper way. And there is a very peculiar observation by Professor Varinder Singh.
Yes.
He said that the most of the empyema in India is by staph.
Yeah.
So urokinase
Urokinase
hardly has any role to play. So it is the drain which is more important than doing any giving any urokinase. So
many of these centers decide upon whether urokinase or VATS with taking many other reasons into play. It is also how much the medical insurance is going to cover the thing, cover the whole expense. So in UK, they would put urokinase and they would not really subject the patient to VATS. And in centers where insurance is going to eat up on the doctors and say, don't do it, they will not do VATS. So I think there is more than what science can see to decide whether VATS is to be done, whether urokinase has to be put on. But the key is please drain the empyema. And I think, Subhashish, you are the Chanakya of today's, Chanakya or the Amit Shah of today's discussion. You are brilliant.
So thank you so much to all the panelists who has done an excellent job. And Shamik, you want to add anything?
No. Thank you.
So thanks to Dr. Indu, Dr. Prakash Vaidya for giving your time from your very, very, very busy schedule. And Shamik is one of the most busy practitioners in Calcutta. So he has spared 1.5 hours time with us, and thankful to him also. And let me...
Before we wind up, there were 1 or 2 questions in the chat box. Somebody did ask a comment on the therapeutic dose of oseltamivir and the duration of treatment, number one. Number two, the availability of the drug in market. And number three, as far as I remember, a question was put in, does the NPA multiplex, does it chase the dead or the live virus? So
Yes.
I've kind of just rattled off all the three questions at one go. To the moderator and to the panelists, please.
So the dose and duration of oseltamivir is 5 days until and unless you can extend the duration if there is any complication, if the child is very sick, but the dosage I don't remember. There's a
3
it
milligram per
depends on
kg,
the wet
3
band.
milligram per kg or
3 mg per kg per dose.
3 mg per
But that
kg.
is below 1 year, but basically it is
That's
given
right.
on a wet band. Below 15 years, it is 2.5 ml twice like this. You can check from any of the pharma books. So far
Can be
as
given above the age of 3 months.
above the age of 3 months, yes. And what is the next question? Comment on the cough syrup. I will take that question. Hydration is very important. PCR multiplex.
Does it
Chase dead or live virus? Yes.
It's a DNA, it's a dead virus. I mean, it can't differentiate.
Okay. And the last question, in three of you, in your practice, a child is coming with a severe cough. How do you manage? What cough syrup you prescribe? What you do? Do you use? My question is, do you use cough suppressants?
So,
And if you are using, what is that?
so I think, first of all, it depends on the severity of the cough, whether it is accompanied with wheeze or not. And third is the age of the child. Okay. If it is a younger child, like an infant, then I generally do not like to use anything. If there's wheeze, I would use a bronchodilator, but beyond that, I would not use. An older kid, maybe 3-4 years, and the child is incessantly coughing, I would use not mixtures, but I would use dextromethorphan. Okay, in the correct doses 1 to 3 milligram per kg per day, and I would be very careful to see that I don't exceed the therapeutic range of the dose. I also would use home remedies. I would tell them, because I have to keep the parents, the child, everyone busy, because sometimes they cough like there is no tomorrow. So tell them, please use honey and please use your home remedies, whatever you want to use to ease the cough. Drink lot of water, hydrate yourself, because hydration is one of the best mucolytics and it is the best cough medication.
Excellent. Dr. Vaidya?
Well, sparingly, I use dextromethorphan in an older child only as a night dose, just to give him comfort from the cough at night, not round the clock.
So do you use levodopa/propofol?
No, I have no experience with that.
Okay. Shamik, you?
No.
Okay.
Yeah, I think so. It's been well explained up till now.
So can we wrap up?
I would just like
Subhasis,
to-
I have one question. Subhasis,
Yes, Arubda, please.
why the hand-foot mouth disease is now so rampant for the last 5 to 7 years?
Yes.
Due to the protection of the polio, as polio is enterovirus and it has been ceased out. So for this reason, being the handful and mouth disease enterovirus, so it is now increased, or any other reason for increasing of the hand-foot and mouth
The
disease?
method of spread is fecal-oral, also through respiratory secretions and also through water. So monsoons always sees an increase in enterovirus. That is one. Secondly, with the opening of schools and children going out to crowded places, therefore the transmissibility and infectivity has increased. So every year we are seeing hand-foot mouth. This year, like other respiratory and enterovirus.
The question of Dr. Arupra is very pertinent. Last 7 to 10 years, we are seeing a lot of cases of hand-foot mouth disease. When I started my practice, say 32 years back, I never seen so many hand-foot mouth cases in a year. But last 10, 15 years, it is increasing. Yeah.
We had a lot more diarrhea then. Now we don't see so many diarrheas.
So there must be some environmental reason for the spreading of the maybe. But anyway, we don't have the exact answer. Thank you.
I would just kind of like to invite the personnel from Dr. Reddy's to give a vote of thanks, please.
Good evening, everyone. I think I am audible, ma'am.
Yeah.
Yes, you are. Yes.
My name is Devabrata Sengupta. I work as a regional sales manager in Grandera division of Dr. Reddy. First of all, sir, it's an honor to be a part of this mega scientific event on behalf of Dr. Reddy's Grandera division, who is the maker of brands like Atarax and Zysel. I really convey our hearty gratitude to all the speakers, participants, and especially to Dr. Shubhashish Roy, who has given us the opportunity to become a part of this mega scientific event. Thank you so much, sir. And I would request Dr. Shubhashish Roy to give us the opportunity in future also to become a part of this kind of scientific program so that we can continue our relationship with this particular society, sir. Thank you so much. That's all from my end, sir. Thank you so much.
Thank you.
Thank you.